Lucas, for a starter, can you please tell us who is Lucas? What do you do and why do you do it?
I'm a physiotherapist. I'm a physiotherapist specialized in treating chronic pain. And this is most likely the reason why you invited me. And this specialty is not very common among the physiotherapists. I, of course, treat the whole spectrum of conditions like acute injuries, like surgery, like post-surgery conditions. But my main focus, something that I promote, something that I learn a lot about, is chronic pain and resolving the chronic pain in a way that it never comes back.
I see. Before I get into the topic of chronic pain, a bit more into details, can you please let me know, like, why did you choose this speciality in particular? Why not something else? What drew you to it, basically?
What drew me there, it was the solutions it provides, the amount of value it provides for the time of the session, the relief it provides, the mission behind of it, because I really have the sensation that I change people's lives, and the satisfaction it provides, and because it saved me. And I'm trying to be the exact therapists that I needed a few years ago, 5-6 years ago. And yeah, that is why.
Let's talk about your, let's say, injury and how did it help you? Like, how did the spectrum of physiotherapy have helped you in getting through your injury? First, let's talk about your injury and what happened. Let me know, for example, and the audience, what was it and how were you able to overcome it?
So it requires firstly taking a step back to understand what was my background before and how it changed because of few experiences. For the first few years of being a physiotherapist, for the first few years of being a physio, I was a physiotherapist working in the gym. So basically, the way I was helping people is I was making them stronger. I was encouraging them to move through pain in a safe way, how to train around the pain, how to get stronger, because even studies prove that this is, to a certain degree, the best thing that a physiotherapist can do for you. It has amazing results. If you are stronger, you will have less pain. You'll feel more comfortable. You will be able to do more. You'll be able to go back to the activities that was painful before. And I was in love in the gym. I still are. Well, maybe I got a little. I'm at the stage when I don't train so much. I leave my body. I allow my body to rest a bit. But the gym is something that I really love. And the gym was the reason why I became a physiotherapist. So I decided to change completely to the manual treatment, focusing on different things in physiotherapy because I outgrew the training part, let's say. I outgrew. You can grow in this direction to the end of your life. Like basically, you can finish more courses, figure out how to change certain tweaks, get even stronger. But I lost so much interest in that when I noticed that there is something better. Basically, the situation that changed my mind was when my knee started to be useless. So I had ACL reconstruction. ACL damage is one of the second most common injury along a lot of sports. It's a pretty common thing. Basically, my ligament in my knee popped during my birthday party. I just had a very rough landing. Something popped, got swelled. I had to undergo 2 surgeries to repair the ligament because without it, my knee was highly unstable. Like it was twisting all the time. So I really needed that. I had 2 surgeries. They helped me. Like I'm not gonna lie, the surgeon did amazing job. For 5 years, I did. Okay, it was not 5 years, maybe 4. I didn't think about that at all. The problem started to built up around 4 years later. The knee started to heat up. It started to feel stiff. I needed to warm it up because without warming that up, I couldn't flex the knee to the end. And I was like, okay, whoop, something is not going to the right direction. I didn't feel comfortable. It was stressing me out. I did I finished the whole standard way. I used the whole standard physiotherapy to resolve that. So massages, right? Strength training. I was constantly strength training. I didn't stop. But I couldn't train efficiently. At some point, training around that was causing much more problem than just enjoying the training. It felt like obligation. I need to train to avoid pain, not train to enjoy. I couldn't get stronger because over a certain threshold, I just couldn't push more. Yeah, because the knee was stopping me. Then I did scans, MRIs. I found the best doctor, orthopedic doctor in my city. And based on the scans, they found that I already had signs of quite a degeneration in my knee. It happens. When someone opens the knee, these things will happen, right? Even without this ligament, right? It's proven that even without this ligament, this bone degeneration will slowly, gradually move forward, which is okay. I expected that, but not that fast, basically. And then at that time, I already started to, in a bit shy way, play a bit with scars, with scar mobilization. I saw that some therapists are using that. I didn't exactly know why yet. I did some experiments on my patients, like we did some scar mobilization before the training. Some people felt it's a bit lighter, it's a bit more comfortable. And I remember this evening, it was in Krakow, the weather was amazing. I was waiting outside for my patient, and I didn't feel well. Like I felt really down because it felt like the retirement is coming, like, basically. Imagine that you have to put the weights on the bar for the patient, for the client, and then you have to and you move like a grandpa. It didn't feel nice. And I was in my shorts and I started to just look for things. I grabbed for the first time in 5 years the scar after the surgery. And I was just about to throw up. Like the tension that I had on that scar was tremendous. Like my heart started to beat up faster, breath speed up. I started to feel dizzy. I felt pulling up to my groin, up to my ankle. I was like, what the hell? That's massive. Like I never, as a physio, I never got an idea that why don't you work on that scar, right? Every other physiotherapist that was working on me, massage here, massage the calf, even around the knee. But no one really spent too much time on the scar, maybe a few moves over, but that's it. So when I found that, I was shocked that I have something like this. I checked the other side. Maybe it's normal for this area. Oh, it's uncomfortable, but it's not that much. After 10 minutes of squeezing that, I felt that it's a good pain, like it's a good thing. After 10 minutes, I was like, wow. I felt like I'm ready to go to sleep. I stood up and my knee felt so light and so comfortable that it was just crazy. It felt like it got younger by 10 years, full range of motion restored without warming that up. And until my next patient came, I released 2 more because ACL is, the entry is through, you have 3 scars basically, 1 big and 2 small. It depends, but this happens in most of the cases. I was working a bit more on these 2. And it felt even better. Then my patients came for the evening shift, let's say, and I just couldn't wait to go back home and just do more of that. Just to maybe put a cup there, maybe I had pins, I had all this physiotherapy equipment. I wanted to do it there, right? I was like, wow, that's the solution. Then for a few months, like my practice already started to shift. When someone told me that they had a scar, I was like, okay, we are going to have a look. No way that we won't. And my knee I remember after this first episode was like 70, 80, maybe 90% better. I could go back to training. It was amazing, like from the orthopedic perspective, amazing improvement. And the last bits of improvement I got when I realized that basically when they create the ligament from so-called graft, they basically go in here, they take a part of your tendon from here, from this place, and they use it to create the ligament. So I was thinking that, okay, so I don't have a superficial scar here, but most likely I have a deep one. So instead of working here, I went to this area and again, almost throwing up, hitting up, and releasing this area gave me the last bits of improvement of the orthopedic one. This scar was still my place of experiments because scar mobilization is a vast subject, massive amounts of technique. There are so many ways of releasing that. And years later, even right now, I still learn a lot on that scars. I try new techniques, new approaches that I find somewhere, that I figure out, that I steal from other therapists. And right now, this knee is amazing. Sometimes I have a feeling that this knee is better than this one. I still have something to do on my right side. But basically, why I decided to move to that. First of all, in 2 sessions, like these main sessions, I gave myself more improvement than throughout the whole training part. Like, I don't say it's bad. It's very necessary. It's very necessary to train, to get stronger. Yoga, Pilates, weightlifting, whatever works for you. But if in 45-minute session I can give someone so much improvement, give that much of a satisfaction that I want to work only in this. I want to feel this niche. I want to explore that. And training I can leave for other therapists, someone who enjoys that. Go for it. See Darius, my good friend. He's working in the gym. He's amazing with that. I prefer to focus only on this. And it solved a lot of my problems. One of the problems that I had when I was a physio in the gym is that at some point your graphic is filled with the same people. Because physiotherapist in the gym, its natural progression is a personal trainer, basically. So you have a patient that you help, he gets stronger, you try to let them go, but they notice that without you, they don't have so much motivation to train. And when they stop, the problem comes back because strength training in a lot of cases is just like it helps to cover up the symptoms. When you are strong to a certain level, because it doesn't work after a certain threshold, it helps you to cover up the pain. So they come back. And now, after working 1 or 2 years in one space, you are a personal trainer, basically. You have the same people. You don't have space for seeing someone else. And that's a big problem, because at some point, you don't feel like you are doing a mission. You are a personal trainer is an amazing mission, don't get me wrong. But you also have to like it. And I had a perception that I can do more, but I couldn't get out of that, because you will not tell people that, okay, now I need to let you go because I need to make a space. From financial perspective, it's a very bad decision. You're feeling like, okay, maybe it's bad to say that, but you have a steady income, right? It's a very comfortable situation. But there was no more place to grow, in my opinion, in my sense.
Let me ask you, scar mobilization. It's the first time that I hear about this term. Like, can you please tell us more about it? And is it a method which you can use for everyone in all the cases? So what is scar mobilization, basically, for those who don't know?
Scar mobilization is a form of manual treatment or instrumental treatment. There are tools that help me to do that without damaging people, basically, without excessive damaging of the tissues. That helps me to restore perfect gliding of the tissues on all levels and helps me to restore the function of the nervous system there. The scar has multiple layers of problems, causes multiple layers of problems. The ones that I solve is the problem on the layer of connective tissue, so-called fascia. If there is a skin, if there is a muscle, there are few layers of connective tissue in between. Some of them are placed diagonally, some of them horizontally. They spread in all of the directions. Thanks to that, when you move your arm, tissues glide on top of each other. Blood vessels, nerve, glide in between the muscles. Thanks to that, nothing is ripping apart. Now, the problem with scar is that when the surgery happens or the injury happens, a few layers of connective tissue are crossed and they become sticky to each other. This adhesion that is being created is created by the collagen fibers mostly and by the hyaluronic acid densifications. This is what we know right now. If we start scar mobilization fast, if we move a lot during the healing process, there will be not that much of a problem with these collagen fibers that are bonding everything around. If this would happen, that's a bit harder problem to solve because we cannot break down the collagen. To break down the collagen, you need the surgery, you need the intervention. But most of the scar adhesion, the adhesion that the scar causes, is made of hyaluronic acid, of densified hyaluronic acid. And what does it mean? It means that if we mobilize that manually, we can release them. If the adhesion is big one, we need to heat that up a bit, either with friction, either with a tool. But when we heat it up, the hyaluronic acid can break down to the glucose. There are a lot of substances in the fascia that are problematic, but hyaluronic acid is the biggest thing.
What's the role of this acid?
Hyaluronic acid is a very long chain substance that bonds water. So basically one particle of hyaluronic acid can bond up to 10,000 more weight of water than it weighs itself. It holds water in connective tissue. Thanks to that, we don't have that much friction. The dysfunction of hyaluronic acid is when, due to the surgery, due to the injury, due to the overuse sometimes, it densifies and pushes water outside. Then it's called densification, adhesion, depends on the school that you finish. In tissues, it is felt like a bubble of tension, as sometimes very small grains next to each other. Sometimes it feels like the massive bulb that has even sometimes 5 centimeters, 6 centimeters. And based on the size, based on the placement, we decide which technique to use the most efficiently to release that tension. Sometimes, if the tensions are very small and very superficial, I have to work very gently. Sometimes, when the adhesion is very deep, is very stubborn, the intervention will be pretty hard and long. It looks like the worst massage ever. Like you just rub one spot for 5, 6, 7 minutes, and then it breaks down. Then the patient is sore for 2-3 days, but when I see him next week, oh, nice, soft. It feels better, and it provides amazing relief on the first session. It's just wow. So this is the connective tissue part of the problem. There is also neurological one. Neurological part of the problem is that the receptors, physically damaged, they become dysregulated. And they can become too numb or too sensitive. And that is why certain scars, some people have a very big problem touching them because they feel weird, they feel uncomfortable doing that, they feel like it's the interrogation, unnatural. I played with that for a bit, when we put a pulse oximeter, how it's called in English, I forgot the name, the tool to examine the pulse of the patient. I forgot the name in English.
I honestly don't know about it. I don't know the name of it, like the scientific name for it, but I know.
You know what I'm talking about. This is the stupid
like
things.
the pulsometer kind of a thing. Yeah.
Basically, I played with that a bit when I was, during the scar mobilization, I was assessing people's pulse. And when I was touching the scar, the pulse went up by 10, 15. And of course, you can say that if I would touch this person anywhere, it would also change because of the stress, but I did that and it didn't change. Yeah. So the scar has a very often the very strong neurological component. And if you have a scar in your body that you feel uncomfortable touching, you may be sure that your body, more or less subconsciously, will figure out how to move without touching that, without compressing that, without stretching that. So you see, if you will have a nice scar over here, your nervous system will figure out that if you use this muscle too much, you trigger this area. Let's stiffen that muscle. But if you stiffen this muscle, you have to stiffen this muscle, you have to stiffen this muscle, you have to stiffen this muscle. And your whole left side feels off, but you don't feel this. You feel that something is off. That pain mechanism is not perfect, it's far from perfect. That's why we very often can't say what is the root cause of our problem. But very often it's the scar.
Very often is the scar. So is the scar mobilization a technique that you can use for basically what kind of injuries or for what kind of pain relieving, in what scenario you can use it, basically? Like, I mean, is it for everyone? Because you told me that it worked for you, but can it be the case where it solves all of the injuries where they have scars in the injury, basically? Did I deliver the question in the right manner? Could I yes, sure. So is this scar mobilization like a technique which you can use for all the patients that you have? Or how would you assess basically if the scar mobilization is the right technique for this patient?
So that requires taking a little step back. Bit bigger explanation. That's amazing that we are doing in the podcast, with the patients, like you have to explain it quickly, and now we have time. That's amazing. So, taking step back. Sometimes my patients are visiting me because they have problem with the scar directly. Tummy tuck, breast augmentation, sometimes fillers, sometimes fracture, sometimes some aesthetic thing. And they feel that this area is pulling, that it feels weird, numb. They don't feel themselves after having it, like something is off. So this is big portion of my patients. So we know that we're going to work on the scar. Then we'll proceed to the examination. I will get back to that. But it's not always the case. Sometimes I have patients with, for example, neck pain that started 3 years ago, and it's always the same neck pain. It's always like this. Sometimes go to the head when it's very bad. There was no injury of that neck. There was never a problem. It just started appearing from nowhere. And no one can help with that. There was dry needling there, massage there, cupping, tried everything. Strength training helps for a bit, but not too much. And that's also my patient. Why is that? Because if I see the patient like this, I always ask about their history. And in this history, I very often see a very big potential, how to call it nicely, an opportunity for scar mobilization that will solve this problem. So in most of the cases, if the pain started 3 years ago, the root cause of that pain was sorry, I got lagged. If the neck pain started 3 years ago, in most of the cases, the root cause happened few weeks to up to few months before this. It doesn't mean that it didn't happen 20 years ago. It could. It could for a lot of reasons, but in most of the cases, it's this few weeks, few months before. So when I ask, for example, you came with a neck pain, I will ask you, did you have any fractures in your life? Oh, I had a wrist fracture 4 years ago. All right? That's the idea. What else did you have? I went for the braces treatment. That I started 3 weeks before the onset of the problem. Another one, okay. It's I know we are going a little bit further from the scar mobilization, but this is still my area of expertise. We'll get there. C-section 10 years ago, and I already have 3 things that could potentially help for that, and the person can live without symptoms here, symptoms around the C-section, but they will have a neck pain. And now it's my thing to connect those. Now, how do I do that? The examination part. I start with the examination of the area where there is a pain. So if it's the scar, I will examine the scar. The examination of the scar. I touch it. I ask how the patient feels like. If the patient is like this, or they tell me they don't feel anything, or already red flag, like I will work there. No matter what, I want to mobilize that scar. Because if there is a neurological component, perception part of the problem, then that's going to be a big thing. Now, I assess the superficial layer. So I glide gently on top of the scar. If I feel small grains, I can spend a little time on that place and I ask how the patient feels. Very often they will tell me, it doesn't feel comfortable touching. I just feel like off. I don't want you to touch it. Like, okay, another thing. Then the gliding, right? I assess the gliding in all of the directions, clockwise, and I check if there is a direction that is more stuck, that is more restricted. That's another thing. Then I check that on all of the layers. I can go deeper. It may turn out that superficial part glides nicely, but when I press a bit harder, and the patient is like, ugh. So it can be on the problem can be on multiple layers. The deepest layer, of course, when I really go into and I look for the biggest ones on the deep layer of connective tissue. And if I'm able to find some things, then it's the good candidate to perform a scar mobilization. And if the patient had problem with the scar, they will notice the improvement. We will work 10, 15 minutes, and I will ask them to stand up to see what is happening. Very often they will tell me, it feels lighter, more in control, more relaxed, softer. And then we continue, and patient is happy. If the patient comes with the neck issue, then it's a little bit more of playing. So there are a few ways of connective tissue and neurological examination that can help me. The connective tissue examination is that I try to find the exact spot that recreates the patient's pain. So for example, in a lot of patients, if I press here, oh, it radiates to the head, it radiates to the arm. This is one of the points. There are plenty, right? Plenty. If I find the adhesion or the tension there, I know which areas in the body are mechanically most related with that area. So I do a quick check. Okay, we have a tension here. We had braces, right? I will check here real quick. Is it bigger or smaller than this one? Smaller, almost nothing. Okay, it's not braces treatment. C-section. Okay, I know that with this area, these areas are mechanically very related for the connective tissue perspective. I will rub that, and it may turn out it's nothing. It's not nothing. Maybe a little bit, but much less than this one, right? Then there was a wrist fracture.